I think there are a number of perspectives we need to consider. One is certainly a patient perspective, and there's clearly some people prefer pharmacotherapy over psychotherapy, and others more psychotherapy over pharmacotherapy. And we know that the patient's preferences should be incorporated in the decision process. We know also that both interventions are effective, and often it is a stepped approach that we often consider most appropriate. So, in other words, the least risky, the treatment that is most tolerable, which is often psychotherapy and cognitive behavior therapy in particular, may be chosen initially, and if a further intervention is required, then we add on pharmacotherapy. It is typically not advisable to start with a combination treatment for a variety of reasons. There might be occasions when people attribute their gains to the drug rather than the intervention, the psychotherapeutic intervention, and by doing so, we might have more severe relapse rates than otherwise. So often the first course should be psychotherapy, cognitive behavior therapy, and if people don't respond to it well, then we choose pharmacotherapy. It should be really geared toward a more personalized approach where patient preferences is included. More recent studies have also examined strategies to enhance particular mechanisms in psychotherapy. An example is the administration of D-cycloserine, which is an NMDA agonist that enhances extinction learning, and we know that extinction learning is a component of exposure therapy. So this particular approach enhances a therapeutic mechanism that we know works quite well. In and of itself, D-cycloserine is not an anxiolytic and does not target the anxiety itself, but rather it only works in conjunction with psychotherapy.